Bismillahirrahmanirrahim. Assalamu alaikum. So today we are going to complete our remaining abdominal hernias because in the previous lecture we have completed the inguinal hernia. Now let's start with the hernia, that is the femoral hernia. So what is actually the definition of a femoral hernia? Now a femoral hernia is the protrusion of a peritoneal sac through the femoral ring into the femoral canal and then downward into the upper thigh. Now let's understand this pattern. So think of it like this. First we have the abdominal cavity. Then from the abdominal cavity we are entering the femoral ring. And then from the femoral ring we are entering the femoral canal. And the femoral canal is then entering the upper thigh. So this is actually the passage of the femoral hernia. Now unlike an inguinal hernia, it does not pass through the inguinal canal. Remember. Okay. Now first understand the femoral sheath, because to understand the femoral hernia we must first know what is the femoral sheath. So the femoral sheath is a funnel shaped fascial sleeve that surrounds the proximal femoral vessels. Here you can see these are the femoral vessels and the sheath that is surrounding them is called the femoral sheath. Now it encloses structures for about 2.5 centimeter or 1 inch below the inguinal ligament. As you can see, it is enclosing the structures 2.5 centimeter or 1 inch below the inguinal ligament. Now it has 3 compartments. Okay, so the femoral sheath have 3 compartments. The first one is the lateral compartment that contains the femoral artery. Laterally we have the femoral artery. Then we have the intermediate compartment. In the intermediate compartment we have the femoral vein. On the medial compartment we have the femoral canal, but the femoral canal is not shown here. So on the medially we will have the femoral canal. So that is actually the compartments of the femoral sheath. Now remember, to memorize this you have to remember a mnemonic that is called the navel. N-A-V-E-L, navel. So in navel, N-A-V-E-L, N stands for femoral nerve, A stands for femoral artery, V stands for femoral vein, E stands for empty space. Empty space means femoral canal. And then L stands for lacunar ligament. So that is actually the arrangement here. Now notice the femoral nerve is not inside the femoral sheath. The femoral nerve is not present inside the femoral sheath. Okay. Now let's move to the next, that is the femoral canal, because we have to study each compartment of the femoral sheath. Now what is femoral canal, and then we will study what is the femoral ring, because I already told you that we are going to break each word in our definition. So what is the femoral canal? The femoral canal is the medial compartment of the femoral sheath that forms the femoral canal. Okay, medial compartment of femoral sheath that forms the femoral canal. Now it actually contains loose connective tissue, fat, lymphatics, deep inguinal lymph nodes that are also called the cloacated node. Okay, the deep inguinal lymph nodes. Then its length is about 1.3 centimeter or 0.5 inch. Okay. Now the next is the femoral ring, because the femoral ring was also mentioned in our definition. So what is the femoral ring? The femoral ring is the upper opening of the femoral canal. Okay, upper opening of the femoral canal is called the femoral ring. And it is normally plugged by the femoral septum or occupied by the femoral septum. Now what is the femoral septum? The femoral septum is actually the condensation of the extraperitoneal connective tissue. So this septum actually prevents the abdominal contents from entering the canal. Now let's study about the boundaries of the femoral ring. So this is one of the most commonly asked viva questions, that what are the boundaries of the femoral ring. So first we are going to study these are the boundaries, and these are the structures that contain these boundaries. So first we have the anterior. So anterior boundary is formed by the inguinal ligament. As you can see in the upper diagram that the anterior boundary is actually formed by the inguinal ligament here. Okay. Then next is about the posterior boundary. So the posterior boundary is formed by the pectineal or Cooper's ligament and the superior ramus of pubis. That means the pectineal or Cooper's ligament, this is the pectineal and the Cooper's ligament, and the superior ramus of pubis is going to form the posterior boundary of the femoral ring. Then the medial boundary is formed by the lacunar ligament. Okay, the lacunar ligament is going to form the medial boundary. And the lateral boundary of the femoral ring is formed by the femoral vein. Here laterally we have the femoral vein. So these are all the boundaries of the femoral ring. So now you have to visualize it like a doorway. Okay. First we have the inguinal ligament that is anterior present. Then we have the lacunar ligament that is present medially. Then we have the femoral vein that is present laterally, and then posteriorly we are going to have the pectineal ligament plus pubis, and these are going to form the posterior boundary. So if you connect all these four structures, they are going to form a ring, and that is called the femoral ring. Okay, and this doorway, remember, or this ring is very rigid. It cannot expand much. So that fact actually explains that almost every complication of femoral hernia is how going to develop from this point, that this doorway is very rigid. Okay, now how does the femoral hernia develop? Let's come back to our main topic. So normally what happens, that the peritoneum is actually blocked by the femoral septum, because we have studied that the femoral septum is actually closing it. So if but what happens, that if intra-abdominal pressure increases, or you can say the femoral ring becomes weak. I told you that femoral ring is kind of rigid. So if it becomes weak or the intra-abdominal pressure increases, the peritoneum pushes through. And that when the peritoneum pushes through, the sequence is going to be the peritoneum. It is going to enter the femoral ring. Then it is going to pass through the femoral canal, and then it is going to reach the finally upper thigh. Now, there is also a question that arises, and that is usually commonly asked by the viva during the viva. So what is that? That is why is the femoral hernia more common in females? Now, according to our book, it says that possibly because females have wider pelvis. These are the possibilities, that the females may have wider pelvis, they have the larger femoral canal. So this creates more room for the abdominal contents to protrude. Okay. So that's the reason that the femoral hernia is more common in females. Now let's study the course of the femoral hernia. So according to our book, the first step is that the sac enters the femoral ring. The peritoneum sac, because of the increased abdominal pressure, either there is a weak femoral ring, then it passes through the femoral canal, pushing femoral septum ahead. Okay. Then on the third step, it is going to emerge through the lower end of the canal. Okay. Then after emerging from the lower end of the canal, it forms a swelling in the upper thigh beneath the deep fascia. Okay, and step 6, if it enlarges further, that means it turns upwards over the inguinal ligament, because the fascia of the thigh restricts downward expansion, because we have the fascia of thigh, fascia lata, that is enclosing it. So the femoral sac or the femoral protrusion or the swelling, it does not have any route to go downward. So that's why it is pushed upward. Okay, so it pushed upward. This explains that why the large femoral hernias may appear close to groin, because it is pushed upward because of the fascia of the thigh is restricting the downward expansion of the femoral hernia. Okay, now let's study its relation to the pubic tubercle. That is actually a very common clinical point here. So inguinal hernia, actually we have studied about the inguinal hernia in the previous lecture. So if you haven't taken that lecture, I'll suggest you to take that lecture, because that is very important. And the inguinal hernia we already studied lies above and medial to the pubic tubercle. The inguinal hernia lies above and medial to the pubic tubercle. But what happens in case of the femoral hernia? The femoral hernias lies below and lateral to the pubic tubercle. Below and lateral to the pubic tubercle. You can remember it is PTFH. Femoral hernia PT. FH PT. PTFH. Pubic tubercle below and lateral to the pubic tubercle, femoral hernia. Okay. Now, so why the strangulation is more common here? So the book repeatedly emphasizes this, that the neck of the femoral hernia is narrow and rigid, and strangulation means obstructed. The something is obstructed. So obstruction is going to happen when when the passage is narrow. So that's why the femoral ring or hernia is narrow and rigid, because it is surrounded by the anterior inguinal ligament, posterior pectineal ligament, medial lacunar ligament, and the lateral femoral vein, and these structures cannot stretch. So therefore the bowel becomes tightly compressed. Now what happens when the bowel becomes tightly compressed, or the structures become tightly compressed? The blood supply gets cut off and the strangulation develops. So this is why the surgeons consider femoral hernia much more dangerous than the inguinal hernia, because the blood supply is going to cut off here. Okay. Now this is also written here that it is initially reducible but later it becomes irreducible. So now why does it becomes irreducible? Because initially the bowel passes into the sac and it returns easily. But later what happens that the neck remains narrow. Now the bowel becomes swollen. So it cannot pass back through the small opening and hence it becomes the irreducible hernia. Now the next line it says that for the femoral hernia is surgical emergency. So why is it a surgical emergency? Because strangulation is occurring here frequently. Once blood supply stops, it leads to ischemia. Ischemia leads to necrosis. Necrosis leads to perforation. And perforation leads to peritonitis. And the peritonitis leads to eventually death if it is untreated. So hence the Snell says the femoral hernia should always be treated surgically because it is a surgical emergency. Okay. Now the next type of hernia is the umbilical hernia. Now an umbilical hernia is the protrusion of abdominal contents through near the umbilicus or navel. Now your book describes 3 types of umbilical hernias. The one is the congenital umbilical hernia. Now the congenital umbilical hernia can be also called the Omphalocele or exomphalus. Okay. Now the second type it is mentioning is the acquired infantile umbilical hernia. And the third type is the acquired umbilical hernia of adults, means the para-umbilical hernia. Okay. And the first we will study about the congenital umbilical hernia or also called the omphalocele or exomphalus. Okay. So what is the definition here? So this is a congenital developmental defect caused by the failure of the midgut to return to the abdominal cavity from the extra embryonic coelom during the fetal life. Okay. Now what is actually the normal embryology? To understand this definition, first we have to know what was the normal embryology of the umbilical congenital hernia. So at about the 6th week, the rapidly growing midgut temporarily herniates into the umbilical cord, and that is actually a physiological herniation. So if it rotates while outside the abdomen, because it is going to grow, the midgut at the 6th week grow temporarily herniate into the umbilical cord, and in the umbilical cord it rotates outside the abdomen. So around the 10th week approximately it returns to the abdominal cavity again. That means the hernia that was developed, it again proceeds back to the abdominal cavity that was first, you can say, herniated or protruded into the umbilical cord. So actually the plain text, if I put it in the simple words, then it is at about the 6th week what happens that the midgut leaves the abdomen. That is called the physiological herniation, and then the rotation happens here, and then about the 10th week the herniation returns back to the abdomen. So what happens in omphalocele? Now what happens in case of omphalocele, because we are mentioning here 2 terms that are omphalocele and exomphalus. So in case of omphalocele, the midgut fails to return. That condition is called the omphalocele. So therefore intestine, what happens that the intestines remain inside the umbilical cord because it is not going to recede back into the abdominal cavity, and they are covered by peritoneum, inner Wharton's jelly and amnion on the outer side. Okay. Now this is actually what is the figure here is illustrating here. Okay, this is the Wharton's jelly, the umbilical cord and the hernial sac shown here. So what are the clinical features of the omphalocele umbilical hernia? That the clinical features will be it will be present at birth. That means it is congenital, so that's why it is present at birth. But then again it is a large swelling at umbilicus. It is covered by a membrane. It is associated with congenital anomalies and it requires urgent surgical management. Okay. Now the second one, let's move to the second type. Omphalocele is actually and the exomphalus are actually the synonym of one another. So that means the both conditions of these both terms are for the same condition. That means in that case when the femoral hernia is not the femoral hernia. I meant to say the congenital umbilical hernia is unable to return back or recede back into the abdomen. Okay. Now the next type is about the acquired infantile umbilical hernia. So this is not congenital in the embryological sense. Okay, this was congenital. It is also mentioned here that it is infantile, but it is not congenital in the embryological sense. Okay, it develops after birth because it mentions infantile because of the why it develops? It develops because of the weakness of the umbilical scar in the linea alba. Because when the baby is born, then the umbilicus is cut here, and there is a scar formed at that point where the umbilical cord was attached, and and sometimes what happens that the structures or the hernia protrudes out of that umbilicus scar, and that is called the acquired infantile umbilical hernia. So what does our book states? Our book states that it is a small hernia and it occurs in children. It usually becomes smaller as the abdominal cavity enlarges and as the scar disappears, and it mostly disappears spontaneously without any treatment, because no treatment is needed here. Now why it disappears? Because as the child grows, the rectus muscles strengthen, because on our midline we have the rectus muscle joining at the linea alba. Then we have the the linea alba actually eventually grows stronger, and the facial defect that was at the time of birth eventually closes. So hence surgically it is usually unnecessary unless it persists. Okay, now the next move to the next type, that is the acquired adult umbilical hernia, or you can say the para-umbilical hernia. Now this is more correctly called a para-umbilical hernia. Now what is the important difference here? It does not pass through the umbilical scar like this infantile hernia. Okay, and then instead it actually passes through the linea alba adjacent to the umbilicus. That means it is not going to protrude from the point of umbilical scar. Here it is protruding at the line of linea alba. Okay, there's the difference here. And this is an important viva point, because the contents here are usually the greater omentum, the small intestine are present here, the large intestine are present here, and the clinical features which the child will, which the adult is going to present will be it is going to gradually enlarged, and it actually hangs downward, and it is more common in women, and its neck is actually narrow, so its neck may be narrow, and it can become irreducible or strangulated because the neck is narrow, and where the neck is going to be narrow, there is always you can say a chance of becoming the strangulated hernia, and that is actually quite a different, or you can say difficult situation. Now from these three hernias I have extracted a comparison. So now the lecture is going to large enough, so there is no more times. You can read or you can screenshot from there the comparison of umbilical hernia. These all are the points that are mentioned here. Now let's study the next type of abdominal hernias, and that is about the epigastric hernia. So now what is the location of the epigastric hernia? It occurs through the linea alba, same, but it occurs between the xiphoid process and the umbilicus. It is not going to occur at the point of umbilicus. It is going to occur at the linea alba, but it is going to occur between the xiphoid process and the umbilicus, any point between them. And this region is actually called the epigastrium. Epigastrium. Epi means above. Okay. Now what is actually the mechanism? So what happens that initially extraperitoneal fat protrudes through the small defects in the linea alba. Okay, but over time what happens that the fat pulls the peritoneum with it, and it forms a true hernial sac. So progression is like that. First extraperitoneal fat, then there is a small defect, it protrudes, then the peritoneal sac forms, and it actually then eventually the omentum of the stomach, the greater omentum usually enters here. Now what are the contents of the epigastric hernia? So for usually it contains, I already mentioned, they have the greater omentum, and occasionally we have the small bowel, you can say small intestine, and then the clinical features from which the patient is going to present is that there will be small swelling, and that is going to be painful on cuffing. When you will ask the patient to cuff, it is going to be painful, and it is actually common in middle-aged manual workers. Why? The reason is because repeated increases in the intra-abdominal pressure weaken the linea alba, and that leads to small defects in the linea alba. Now the third type of abdominal, or you can say the fourth type of abdominal hernia is the separation of the recti, and this is actually called the diastasis recti. And this is actually not a true hernia, that's why a hernia is not mentioned here. And there is no defect in the abdominal wall during the separation of the recti or diastasis recti. So what happens? Instead what happens that the linea alba becomes stretched So the linea alba becomes stretched, causing the two rectus abdominis muscles to move apart. They are separated, and the causes, what are the causes? And that leads to the small defect here. Okay, now what are the causes here? So according to our book, the causes can be elderly multiparous women, because what happens in multiparous women, that they have a weak abdominal muscles because of the C-section, or you can say multiple deliveries or multiple pregnancies. They have a weak abdominal muscles, and that repeated pregnancies stretch the linea alba. Now, what are the clinical features from which the patient is going to present? Is the during cuffing or straining, the recti abdominis is going to separate widely. The abdominal contents are going to bulge forward, and and that is happening because the fascia remains intact. So that means that there is no true risk of hernia. That means there will be no protruding of the contents, and there will be no chance of strangulation also. But the treatment may involve abdominal support or surgical repair if it is severe kind of. Okay. Now let's move towards the next hernia, that is the incisional hernia, and the incisional hernia occurs through actually a previous surgical incision, because like sometimes there is a surgical incision was given during a previous surgery of a patient, but it was not actually properly treated, so that can lead to the incisional hernia. And it causes can be, and there are majorly two causes listed in our SNELs, that are first is the damage to the segmental nerves, because during surgery nerves supplying the abdominal muscles may be cut. That is actually very common, and that actually results in what happens, that muscle paralysis, and there is a weak abdominal wall, and that leads to the incisional hernia. And the second cause can be the wound infection. Now what happens in wound infection, that actually the wound infection leads to the tissue necrosis, and that leads to the poor healing, and that leads to the weak scar formation. So the later the abdominal contents may protrude through this weak scar, and that can lead to the incisional hernia. Now what are actually going to the features with which the patient is going to present? So what happens, that the neck is usually wide here, so there is no chance of strangulation, and there is no chance of adhesion here. Okay, so that was the clinical features here in the incisional hernia. Now let's move toward the next sixth type of abdominal hernia, and that is about the Linea semilunaris hernia, and that is also called the Spigelian hernia. Okay, now this is an uncommon hernia. This is not very common. Usually you are not going to see that much patients in the on the OPD. Now the site at which it is going to occur is it occurs through the aponeurosis of the transversus abdominis at the Linea semilunaris. The aponeurosis of the transversus abdominis is actually going to lead towards the hernia of the Linea semilunaris, and it is just lateral to the rectus sheath. Okay, it is just lateral to the rectus sheath, and it is usually found below the level of umbilicus. Okay, this is also. And now what is the clinical importance of this hernia? So unlike incisional hernia, the neck is narrow here. That means there is a very common chance of adhesion and strangulation. That means the adhesion and strangulation of the contents are common here. Okay. Now the next kind of hernia is about the lumbar hernia. Now the lumbar hernia actually occurs through the lumbar triangle, that is also called the Petit's triangle. And let's study what is the Petit's triangle and what are the boundaries of the Petit's triangle. So what is the Petit's triangle boundaries? The anterior boundary is formed by the external oblique muscle. External oblique is going to form the anterior boundary. Then the posterior boundary is going to be formed by the latissimus dorsi. The latissimus dorsi muscle is going to form the posterior boundary, and the inferior boundary is going to be formed by the iliac crust. And the floor is going to be formed by the internal oblique plus transversus abdominis. Okay, the internal oblique and transversus abdominis forms the boundaries of the Petit's triangle. The boundaries of the Petit's triangle, I have just mentioned the three of them here. The fourth one is not mentioned, and that is about the inferior. That is about the floor, and the floor is formed by the internal oblique and transversus abdominis. So I will suggest you to write it down somewhere. And now, what happens? This area is actually a natural weak point in our posterior abdominal wall. Okay. Now, what are the features? The neck in this case of lumbar hernia is usually large. Therefore, the strangulation is very uncommon here. Okay. So there is no risk of strangulation here. Now let's move towards the next hernia, and that is about the internal hernia. Okay, now what is the internal hernia? So unlike other hernias, there is no external swelling in case of internal hernia. That's why it is called the internal hernia, because there is no external swelling. Okay, And then what happens instead, there is a loop of intestine that enters a peritoneal recess inside the abdominal cavity. So what happens, there is usually the peritoneum is going to form a lot of spaces in the abdominal cavity, and we are going to study these recesses in the next lectures afterwards. But what happens there, so now just right now you have to just know that there are a lot of recesses formed by the peritoneum. So what happens, that a loop of intestine, it enters a peritoneal recess inside the abdominal cavity, and the book is actually giving the example here of the duodenal recess. So what happens in duodenal recess, the intestine, the duodenum may become trapped and strangulated internally, leading to the intestinal obstruction, okay, in case of internal hernia. And what are the symptoms that are going to include here, that there will be colicky abdominal pain. That means there is going to be a lot of abdominal pain, and there is going to be vomiting, and there is going to be no external swelling, and the intestine becomes trapped within the peritoneal cavity, and that can also lead to the intestinal obstruction and distension, okay, and the distension and the diagnosis. So the diagnosis often requires, because it is not external hernia, so in this case the diagnosis often requires the CT imaging, and the treatment is usually surgical here, okay. Now the next is about the abdominal stab wounds. And the abdominal stab wounds is actually not any kind of hernia, it is actually a stab wound, and that leads to the scar formation, and that may lead to the protrusion of the abdominal contents. So the abdominal stab wounds, actually this section lists the layers that are pierced by a stab wound depending on the site, okay. Now if the stab wound happens lateral to the rectus sheath, so the lateral to the rectus sheath, what are the layers of the abdominal wall that are going to be pierced? Actually this is the very first lecture of our abdomen, so I should be asking you, all the people, that what are going to be the layers that are going to be pierced here, because these I have already told every detail, every point to you in very detail, but let's discuss it again. But before I will starting this topic, I will suggest you to pause the video here and first try to test yourself before, okay. Now let's start. What happens if the stab wound is lateral to the rectus sheath? So from superficial to deep we are going to move. So what is the first layer? That is going to be initially skin, then we are going to have the fatty layer of the superficial fascia, that is called the Kemper's fascia, if you remember. Then we are going to, the third layer is going to be pierced, that will be the membranous layer of the superficial fascia, because superficial layer fascia is dividing into the two layers, fatty layer and the membranous layer, and the membranous layer is called the Scarpa's fascia. Then after that we have this, from the superficial fascia down we have the deep fascia, then we have the external oblique muscle, or you can say the aponeurosis, then we have the internal oblique muscle or aponeurosis, then we are going to have the transversus abdominis below it muscle or aponeurosis, then below the transversus abdominis there is a transversalis fascia lining the transversus abdominis, and then below the transversalis fascia we have the extraperitoneal connective tissue, and it usually contains fat, and then after that we are going to have our parietal peritoneum, and the stab wound, if it is piercing the parietal peritoneum, that it is a very much chance that it can pierce our abdominal viscera, okay. Now what happens if the stab wound happens anterior to the rectus sheath? Then what are the layers that are going to be in way? So the first will be the skin ultimately, then we have the Kemper's fascia, then we have the Scarpa's fascia, then we are going to have the deep fascia, then we have the anterior wall of the rectus sheath, because it is happening here at the level of the rectus sheath, and the rectus sheath or rectus abdominis muscle is just present medially. It is a long vertical strap muscle in the medial part of our abdomen. So that's why while we were discussing lateral to the rectus sheath, there was no mentioning of the rectus sheath, but because this point is happening at the rectus sheath, so there will be rectus sheath, okay. Then after the rectus sheath we have the rectus abdominis muscle, and then after the rectus abdominis muscle we are going to have the superior and the inferior epigastric vessels, because I have already told you that the superior and the inferior epigastric vessels that are going to supply the abdominal layers is actually present behind the rectus abdominis muscle, but before the posterior wall of the rectus sheath. That means these vessels are present between the rectus abdominis muscle and the posterior wall of the rectus sheath, okay. Then the posterior wall of the rectus sheath above the level of arcuate line, if it has happened above the level of arcuate line, and then we have the transversalis fascia, we all know. Then after the transversalis fascia we are going to now all of you are going to ask me a very silly question. The students usually ask very silly questions here, and that is about the where are all the muscles. So my dear, the rectus sheath is formed by the aponeurosis of all the muscles. When I am mentioning the rectus sheath, that means I am ultimately talking about all the three muscles aponeurosis, because all the three muscles aponeurosis are forming the rectus sheath. Okay. Then after that we have the extraperitoneal connective tissue, and then after the extraperitoneal connective tissue we are going to have the parietal peritoneum eventually, and that after that the wound, or you can say the knife is going to enter the abdomen. Then after, if the third point where the stab wound may occur is at the midline, that means eventually, or you can say actually at a very exact point where the linea alba is present very medially. Okay, so what are the layers that are going to be pierced here? Because you all know that there is no rectus muscle here in the medial point, so the layers are going to be very simple. First we are going to have the skin, then we are going to have the Kemper's fascia, that is the fatty layer, then we are going to have the Scarpa's fascia, that is the membranous layer, then we are going to have the deep fascia, and after the deep fascia we are going to have the linea alba, because it is happening at the point of the linea alba, and then after the linea alba we are going to have the transversalis fascia, because the rectus sheath and the, you can say, the aponeurosis of the muscles are not present here because they are ending here. Okay, and these are going to form the linea alba, they are thickening here, and that is called the linea alba. And then after the linea alba we are going to have the transversalis fascia, then we have the extraperitoneal connective tissue that may be containing some amount of fat, and after that we are going to finally have the parietal peritoneum. So that was all. Now there is also some point that is mentioned, and that is about in our book of Snell's, and that is about the peritoneal lavage. So what is peritoneal lavage? So the book also mentions the peritoneal lavage here, and that means after an abdominal stab wound occurs, the saline is introduced into the peritoneal cavity and then recovered. Okay, the saline is introduced into the peritoneal cavity and the peritoneal cavity then recovered. So the presence of blood, intestinal contents, bile or bacteria suggests that injury to the abdominal organs, and helps determine whether the surgery is needed. That means they're actually saying here, if there is some stab wound in the abdomen, so and we introduce the saline, then eventually the peritoneal cavity can recover, and the question that whether the surgery should happen or not, that is actually depending on the presence of the blood at that point, the intestinal contents that are pierced at that point, because you know in the C point there are very little intestinal contents. That means there is not the most damage is not happening here, and there are a lot of layers. There are 11 layers. That means there will be, if the stab wound is happening here, that means there is going to be a lot of, you can say, the lot of abdominal contents or intestinal contents are going to be pierced here. So the presence of blood, intestinal contents, bile or bacteria are actually helps in deciding the management and deciding whether the surgery is needed in the patient or not. So that was all about our today's topic and all about the abdominal hernias. All the abdominal hernias are completed here.